We're so glad you're here and that we're continuing this really important work in figuring out how we as a group can better care for bladder cancer patients in survivorship. So I am going to try and do this. Did that work? It did work. Look at me. So I'm Mary Dunn. I'm a nurse practitioner at UNC in Chapel Hill. I work in a multidisciplinary role in that half of my time is in urology, taking care of patients who've had surgery for their cancers, and the other half of my time is working in medical oncology, taking care of patients who are getting systemic treatment or have had systemic treatment. And I treat not only bladder cancer patients, but all genitourinary malignancies. And I've been a part of the BCAN community for over a decade, and I'm thrilled to be with you all. To my right is kind of my West Coast twin here. Krisztina Emodi is a nurse practitioner at UCSF and does an extraordinary amount of work in this space in survivorship and bladder cancer care and GU malignancies. So happy to have Krisztina be my partner in crime on all of this. So welcome to everyone. So why are we here? So I'm going to read this because I think, not because you all can't read for yourselves, but because I think hearing this out loud is important. The purpose of the work that we've done up to this point with this task force and what we are hoping to continue to do and accomplish during this breakout session and beyond for those of you who are interested. It's highly possible that you'll listen to me ramble on for 2 hours and want nothing more to do with this, and that's also okay too. I don't have feelings anymore, so they can't be hurt. But I do hope that many of you will be interested in continuing on with the work. You'll see a survey data that we've collected over the past year that I think is quite interesting and eye-opening, and hopefully we can get some projects going out of that. You're welcome to also ground me. I tend to think big, but having realistic goals for this work I think is going to be helpful as well. So the purpose of this breakout session is to improving survivorship care remains a key focus of BCAN and the greater bladder cancer community. To better understand the needs of bladder cancer patients and their caregivers, the Survivorship Task Force has developed and disseminated surveys to gather data to use to work toward future projects. Surveys have also been distributed to a diverse group of providers who care for bladder cancer patients to determine what survivorship programs already exist and to get input on how to improve survivorship care. This session will highlight the data that has been gathered from these groups, and then we're going to focus on potential areas of research. Okay, so I always like to know who's in the room. I won't embarrass everyone by making you do a 5-minute introduction of yourself, but just with a show of hands, who in the room is an advanced practice provider, so nurse practitioner or physician assistant? Sweet, awesome, representing. Where are my nurses? There's my nurses. Nurse practitioners still count as nurses. Do we have any physician colleagues with us today? No physicians? They're behind the scenes. I harass them all the time, so that's okay. And patients, people who've had a bladder cancer experience. Excellent, welcome. Caregivers, so those who love someone with bladder cancer. I mean, all of us do, but you know what I mean. People who do research. Excellent. Industry partners, sorry I left industry partners off the list. Anyone else who does not identify with anything on my list? Did I leave someone out? I typically do. Well, thank you all. This is fantastic and really warms my heart that all of you are here. I think we've got a good representation of folks who can really help us with these projects. So how do we define survivorship? There's lots of definitions of survivorship out there on the planet, but this one I like because it's relatively concise. I am not, this is. But an individual is considered a cancer survivor from the time of diagnosis through the balance of their life. Family members, friends, and caregivers are also impacted by this and included in this definition, so I find this to be concise and inclusive. What is survivorship? It means different things to different people. I bet we could take everyone in this room who's had a bladder cancer experience and ask them what survivorship means, and we'd get very different answers, and that's fine. There's people will say, well, it's having no signs of cancer after treatment, so post-cancer treatment survivorship, kind of on surveillance, no evidence of disease. that means I've survived this. Or kind of a more broad living with cancer, living through cancer, and beyond cancer, which I think is also a good way of putting it. And then there's others. The term survivorship doesn't feel right to everyone who's had a cancer experience. We use this term just because it is the term in the cancer world, but sometimes people don't prefer to call themselves survivors and have different language for what works best for them, and being respectful of that. And then there's so many individual challenges and concerns in this space once someone has been diagnosed with cancer, is going through treatment, is on the other side of it, or has advanced disease and is living with advanced disease. For the focus of this initial survey that we put together, we really did focus on people who were kind of in the post-treatment surveillance phase of their experience. But I think for future endeavors, we're also going to look more into folks who are living with bladder cancer in the advanced stage, because I think there's some needs there as well. Also, if anyone has any questions while I'm rambling, please feel free to interrupt. So I like numbers. This is just general cancer survivorship data, and these data are from 2022 from the American Cancer Society and the National Cancer Institute. So these are the kind of the latest big numbers that are out there, but there are 18 million people with a history of cancer in the United States. That's extraordinary, right? And the number of cancer survivors is projected to increase by about 25% to close to 23 million people by 2032 and 26 million people by 2040. And in the next 10 years, the number of people who have lived 5 or more years after their cancer diagnosis is projected to increase to approximately 30% to 16.3 million. And we know that a lot of people who've gone through a cancer experience are older, so 65 or older. So why is this important? Well, I think it's important because this means that we're going to be seeing on the provider side a lot of people who have gone through a cancer experience, who have unique sets of needs that we just may not be addressing in ways that they need us to. So that's why this is so important. These are vast numbers. So this slide makes me a little bit bananas. I don't know if you can see this, but these are data from the American Cancer Society. Again, this is the most updated data from 2022. But it's the estimated number of cancer survivors in the U.S. by site. So they clump bladder and kidney together, which I don't know if that makes sense to anyone else, but those are two very different organs, and that's not kidney in the sense of upper tract urothelial. That's just kidney cancer. So, I've got some emails out. I'm not anticipating anyone to write me back on that, but just so you know, bladder cancer is a distinct cancer. But there are some bladder cancer specific survivorship data that we were able to kind of pull up. So again, these are the latest numbers from 2022. Approximately 790,000 bladder cancer survivors living in the United States. That's not a small number. And for all stages combined, we know that the 5-year relative survival rate is 77%. So a relative survival rate compares people with the same type and stage of bladder cancer to people in the overall population. That's what that statistic means. We know that post-treatment surveillance for people who've had bladder cancer is crucial. We know that non-muscle invasive bladder cancer has a very high recurrence rate. We know it's the most expensive cancer to treat on a per patient basis. We know that muscle invasive bladder cancer has a high rate of recurrence. So there's a lot of post-treatment surveillance that is absolutely crucial in making sure we're doing that well. But not only, and we'll talk about later, this kind of gets to my next point, there's really no standard of care for managing post-treatment and long-term survivorship needs outside of NCCN guidelines or other guidelines that say do the cystoscopy at these intervals for this long, or get the imaging at this interval for this long, and then you're done. Well, that's just part of it, right? So when we think about survivorship, I kind of think about it in 3 different buckets. So number 1, all the diagnostic stuff that needs to be done, which obviously is crucial to make sure people are still cancer-free. And then thinking about all the things that we on the provider side have done for long-term side effect management, right? So are people still having chronic chemo-induced peripheral neuropathy from their neoadjuvant chemotherapy? Are they having urinary issues long-standing from their BCG treatments? And the list goes on. And then the third bucket is kind of everything else, where we think about the diagnostics, the post-treatment long-term side effects, but also all the other things, right? Because at the end of the day, people are more than just their cancer diagnosis. They're more than just that bladder cancer diagnosis on that piece of paper. So thinking about things like wellness and exercise and smoking cessation and nutrition, making sure everyone has a primary care. That is one of my biggest things, is that people need to have primary care providers to make sure they're up to date on all the other health-related issues, diabetes screening, cholesterol. So this is an enormous thing to be thinking about as far as standard of care. So our goal here is not to standardize care for every institution in the country that provides care to bladder cancer patients. That's not the goal here. Wouldn't that be lovely? But that's not. I also try and live in reality most of the time. But it really is just to kind of work together to build a framework for what we as the group think that this could and should look like, with the understanding that there are tons of barriers to everything we're going to discuss, which we'll highlight, and then talk about as a group, how can we overcome some of these barriers for patients, caregivers, and also for the healthcare systems as well. If I had a magic wand and could make all of this work the way that I wanted it to work, then I would do that. But that, again, trying to live in reality here. All right, so for those of you who attended our 2022 breakout session, thank you so much for coming back, even though I'm still at the microphone. I really appreciate your trust in me to carry on, and Krisztina for her efforts by my side as well. So from that session, where were we last year? We were in Denver? Denver last year. So it was a great group. I see a lot of familiar faces here, so thank you all for coming back. And I see some new faces, so thank you all for joining us. But at that breakout session, we had sent out a pre-think tank survey, much like we did this time around. And that was identifying how different groups viewed the most important issues surrounding survivorship. So we sent that to providers, patients, and caregivers. So that came about where we kind of like laid the framework for what work we were going to do for this year, leading up to Think Tank 2023. So there was a lot of concerns around uncertainty and worry related to recurrence, post-treatment related side effects, and then emotional and mental health concerns from the patient side. And then shaping the future of survivorship-focused research, thinking about things like survivorship-specific clinics, support groups, and survivorship care plans, and what are some steps that we, I say we, the collective we, and BCAN can help with to work through some of these things, knowing that a lot of these things are big tasks. So just kind of taking it one step at a time. So thank you all for being with us last year and for coming back this year. So what have we done in the past year? Well, there are those of you who have been on the quarterly calls on Fridays with me. Can you just raise your hand as part of the task force? Big shout out. Thank you guys so much for your input and for dealing with my Friday unwashed hair sitting on my couch on my academic day in my sweatpants trying to get through these meetings. Your input really has shaped the next steps for how we're going to move forward with all this. So thank you to those of you who over the past year have given your input in whatever form you've been able to. So we developed a survivorship task force. So how we kind of did that was last year, took down a bunch of names, sent out some emails saying, hey, if you're interested, please join us. And basically we were having quarterly meetings about what can we as the group do for those of us who are able to join. We ended up having 5 meetings to review and share ideas for how the BCAN community can meet the needs of survivors or people who've had a bladder cancer experience, identify gaps, and then discuss potential projects. We developed both a provider and patient survey, and you'll see by the numbers, but our patients kind of kicked our butts on as far as the number of people who responded. Some of you might be in the room, but those data really helped kind of narrow our focus for what we're going to talk about today and moving into the future. Excellent. Yeah, a patient or provider survey for, yeah, awesome. So a decent number of you, thank you.
We sent out a lot of tweets and a lot of
Desperate pleas, yes, so thank you for probably deleting my first 5 emails and finally responding to the 6. I do appreciate it. I know there's survey fatigue, I get it, but thank you, yes, and thank you for posing the question. Trying to coordinate here. Okay. So this is just a very basic review of a very quick literature search. So those of you who were on that first task force call that we did, I shared this information and it was just like insanely frustrating. So this was go to PubMed and just put in very simple terms and see what pops up, okay? So this data, I think, when was our first meeting? In the fall, I think. So I think I showed this in the fall. I didn't update it because it probably wouldn't have changed much. So I typed in bladder cancer survivorship into PubMed and got 153 results. Okay. Then I typed in bladder cancer survivorship clinics and got 69 results. And while I was perusing through these articles, granted it was relatively quick, some of these papers that came up in the search had absolutely nothing to do with bladder cancer or survivorship. So I'm like, well, do I email the people at PubMed? Like, I'm going to get blocked from the email with all the emails that I send complaining about how bladder cancer is not well represented in anything. But anyway, that's beside the point. So these numbers, and then I was like, well, what else is out there for other cancers? So in GU world, we see a lot of prostate cancer, right? So I see a lot of men who've had a prostate cancer experience, and when you type in prostate cancer survivorship into PubMed, we get, oops, I'm clicking the wrong button, my bad, 804 results. And if you pop in prostate cancer survivorship clinics, you get 391. So there's a bit of a discrepancy there, right? Now, bear with me. The last thing I looked up, because I was like, all right, GU cancer, but let's look up another cancer that we know gets a lot of funding. So I typed in breast cancer survivorship. Holy cow. And I'd be willing to bet if I did that now, that number would be even larger. And then breast cancer survivorship clinics, right? So there's lots of discrepancies here. And I think there's a lot of reasons for this. I think it is, I think funding is an issue. I think interest is an issue. I think being really loud on Capitol Hill is an issue. I think there's a lot of reasons for this, and I know that we can't make a giant wave here, but I want to make a dent in this because at the end of the day, our patients who've had bladder cancer experiences deserve to have really good survivorship care as well, and something that we need to be looking into. So thank you for bearing with me while I put up a little cynicism there. Is anyone surprised by that? Yeah. Okay. These are just some examples of existing papers. That didn't fit well on the slide. Sorry about that. Good Lord. But some of these people are at this conference. There are people who've done really important work in survivorship. Heather Goltz, for heaven's sakes, has done a ton of work in this space and continues to do so. Lots of people who come to the think tank, and there's more work to be done, which is why we're here. Okie dokie, so getting down to the numbers. All right, does anyone have any questions for me about those slides before I get into our survey results? Very good? Okay. Thank you for bearing with me. All right, so in reviewing our survey data, Our healthcare provider survey, we got 80 responses, so our goal for both surveys was 100. So I wasn't going to log in 20 more times just to skew the data to get my 100 for healthcare provider survey. But we were close. We were close. But the patients kind of blew us out of the water. We got 135, and I know that Bob and Karen were instrumental in making sure that happened. So thank you. I know Krisztina, you were too, out there on the West Coast. So the surveys were open for 4 months. For those of you who took the surveys, I would love to hear feedback on them as far as how did they get to you, and were they like good links and that kind of stuff. Links as in length, not link as in click on a link. Sorry, I can't enunciate anything today. So we had our survey open for 4 months, and the ways that we tried to disseminate it were through social media, so a lot of Twitter stuff, emails. So we sent kind of targeted, that sounds aggressive, but targeted emails to people who we knew. I sent out a big email blast to a bunch of community urologists because we really wanted, both of us work in academic medicine. A lot of people get treated in at academic centers, but we really wanted to have kind of a broad view of what survivorship care is like everywhere. There were messages that went out on think tank emails, so thank you BCAN team, support groups, online forums. So we really tried as hard as we could. It's hard to disseminate these things, right? Like if it's a challenge, but I think we did pretty darn good for what we had. So thank you for those who participated and for who pushed them out and their respective people. So we're going to start with the provider responses. All right, so roles in, the first question was, what is your role in the care of patients with bladder cancer? We had a lot of urologists answer. I was very proud of my urologist, and it has nothing to do with me like standing next to them with the computer, I promise. This is not all UNC data, I promise. But look at the nursing representation here and the advanced practice provider representation here. So I'm really proud of that as well. So thank you to those in the room who took the survey. What best describes your practice setting? Well, as much as I really tried to get this out to people who weren't solely academic medicine, you can see that it was mostly people who work in academic settings, which is not terribly surprising. The other there was someone like wrote in something and it just said HMO, so that was the other. Does your practice have a bladder cancer survivorship clinic? Now the answers to this, so Krisztina and I have a giant, thanks to Morgan and to Patricia, have this like giant Excel spreadsheet of like each individual data. And I know who from my institution answered this question, and a lot of them answered it incorrectly. Because we don't have a bladder cancer specific survivorship clinic, but they think that I run it. So there was like a fill in the blank, like who, I think it's the next question, but like, if you do, who runs it? And I was like, Mary Dunn. I was like, when did I start doing that? So I think there's some education to be done about like, what exactly is a survivorship program. So I do provide bladder cancer survivorship care. I absolutely do that. It's just not in a formal, like, dedicated survivorship clinic space or setting. It's mixed in with like my prostatectomy follow-ups and my kidney cancer follow-ups. So while I appreciate, and you got a lot of shout outs on that Excel spreadsheet too. It's like she does everything at UCSF. So it was interesting to kind of see how incorrect that was. But anyway, so for the folks who answered yes, and if so, who runs it? It was mostly, this program is run by our advanced practice providers, so nurse practitioners and physician assistants, some uro-oncologists, and there was a lot of, I don't know, not sure. And then for the people who said, no, they don't have a specific survivorship clinic, there was a mixture of, yes, this is something I'd be interested in, or no, this is something that I wouldn't be interested in. So that's kind of where all those other little lines are there. I thought I would not bore you all with the Excel spreadsheet because it gives me a headache. I I love this because look at how many benefits people think there are in having a dedicated bladder cancer specific survivorship clinic. The top one was continuity of care, right? That's really important to people. To having that person kind of be their person for whatever time frame they're going to be doing their post-treatment surveillance. The second most frequent answer was access to resources, so that was very broad. Number 3 was care by experts, so people who know what they're doing. But as you can see, this is still the provider part. Yeah, yep, yes. So I think that this is very reassuring that people identify that there are benefits to potentially having a dedicated time and space for patients with that. The little other there, so I tried to extrapolate that from the spreadsheet, was collaboration with other colleagues, specifically nutrition and our awesome WOCNs, and addressing long-term issues. Yes.
Sometimes I think it's really valuable to look at the ones that get ranked low as opposed to the ones that get ranked high.
That is a very good point.
So, I'm curious, survivorship care plans, did they rank it low because that's something that they didn't have?
I can absolutely guarantee you why that was ranked lower, because it's another thing we have to do.
Right.
Exactly. Yeah. I mean, that's just based on what I know about having to do these things, but it's another thing that like the provider would have to do.
So I think that points to something that we need to work on.
Yes, that's on the list. Bob, you're always in my head. Bob is always in my head.
So it's interesting to me that.
Do you want the mic? I tend to be the loud one.
Oh, it's okay. So it's interesting to me to look at the other coming from our colleagues, because if we bunch the ostomy or any of the WOCN parts, I happen to do it also, but it is really, really complicated. And when we're looking at the long-term issues of, for example, having an ostomy, right? I cannot even tell you, for example, how many peristomal hernias we end up repairing with general surgery. We have data to, within 5 years, 50% of our patients will develop peristomal hernias, no matter how well we train them or educate them. And so, as Bob said, the other is really important because we simply don't have enough WOCNs. I took it under my wing because once I jumped into urology 8 years ago, it was non-existent. Like nobody could help me, so I ended up, doing my certification and courses. Currently, UCSF has one ostomy nurse practitioner in a cancer center, one. And then we have an additional person at Parnassus who basically sees all the in-person complex cases before discharge. Continuum of care, I end up seeing patients, I have absolutely no idea where they come from, who they are, whatever facility they came from. So the other is very important.
Thanks, Krisztina. So, I forgot, because I forget things. We're going to try in like the first hour or so until roughly 11:30-ish, go through all of my mind-numbing slides, and then just like open it up and try and narrow down areas of focus. We have some ideas, but getting everyone's input, I think in the last hour-ish of the session. Also, after this is lunch. For those of you who are interested in continuing to carry on this discussion, because I believe that this could be an entire day discussion, quite honestly, I think that we're allowed to have this room if you want to grab lunch and come back. Also completely understandable if you need a break from this. All right. There cannot possibly be any barriers in healthcare. That is not a thing that exists on the planet. So this, for those of you who are healthcare providers, are probably not shocked by any of this in any way, right? So the top 3, Bob, I'm going in order of like what you told me not to do. The top 3 barriers identified by folks who filled out the survey were staffing shortages. Anyone feeling that pain right now? Yep. Lack of funding, where does the money come from to support this and whatever that looks like? And anyone have free time these days? All of it? Lots of free time? Yeah, no. So time restraints, right? So these are barriers, again, these are barriers that exist in everything we try to do in healthcare, so I was not in any way shocked by these. And again, not something that we as a group can fix every single institution and every single barrier, but at least to get the discussion going on how we could potentially make changes. Okay, so then we asked about care plans. So who of you who is a provider have ever given a care plan to one of your patients? Handful? Okay. As on the patient end, has anyone ever received one? Survivorship care plan, formal document? Not a one. Okay, cool. All right, we're doing a good job here. So, thanks, guys. That's great. So for those who answered yes, the little caveat there was if yes, who delivers it? And it was mostly the advanced practice providers. And for those who don't deliver survivorship care plans, they answered no. The kind of write-in feedback was mostly positive, that this would be something that they'd be interested in learning more about. The negatives here are time restraints and integrating it into Epic and not knowing when and where and how to do it. So, does your area have a bladder cancer support group? There was some yes. There was yes at my institution, yes, but it's independent of my institution, and then there was majority didn't know. Oh, I'm sorry. I'm trying to do two things at once. Okay, so for those people who had a survivorship program, we asked several questions. So is it bladder cancer specific? Is it a mix of all types of GU cancers? Is it a general oncology clinic where a patient can have a consult? That's a model. There's lots of models of survivorship care. Is it a collaboration between the cancer team and primary care? Or is it other? So you can see that for those who have a survivorship program, or in the instance of my wonderful partners who think we have a survivorship program that I run, it was mostly bladder cancer specific. So the folks who answered other, it was just a lot of I don't know, unsure, and there was a couple of prostate cancer only in there as well. So for those who yes ma'am, Karen.
On the previous slide, when we asked which centers, which providers had bladder-specific programs, did we ask for any information? Like which center it is, or is it just kind of?
I believe that is buried in that Excel spreadsheet.
Okay.
Yes. Yes, which I can get.
Okay.
Yeah. Thanks, Karen. Yes, sir.
I guess a similar question would be, I would assume that most providers responded that there was 0 or maybe 1 person taking care of all of this. Were there any places that had more than 1 person? I was wondering how their responses would be different to everyone.
That's a good question. We didn't get that specific. There were some folks who did kind of a fill in the blank and said, a nurse practitioner does this, a physician assistant does this, or very generally like our APPs do this, or our urologic oncologists do this, but that's actually a really good point. Thank you.
Mary, one other thing is you were talking earlier about care plans.
Yes.
I wonder even if we think about care plans going from a provider or from an APP to a patient, is this going to be something that's quickly written down, not formal? Is it something that's standardized? If we're talking about a standardized survivorship program, would there be a standardized care plan? Okay, this is our plan for you that's put down, and it goes from place to place along their progress.
That's yes. So and we'll touch on this, I think in the patient section or the idea section, but the survivorship care plan that we have at UNC is embedded into Epic, which is our electronic medical record system. And it imperfectly pulls in people's data. So there's the section if people got chemotherapy, what surgeries people have had. Unfortunately, it doesn't just like pull in TURBT or cystectomy. It pulls in every freaking surgery that they're listed in their problem list. So it's like their appendectomy and like all the things they had, like their tooth extraction. It pulls in radiation data, and then there's some fill-in fields for us to put in for people. It is it is certainly imperfect. There are a lot of examples of survivorship care plans. I have a colleague who is working on one for me that's sitting in my email that I will look at, I promise. And that's part of what we were thinking about, because BCAN has one, but just kind of seeing if we can make it more concise, make it more, it's supposed to be a tool that is helpful for not only the provider and the patients and their caregivers, but also as a communication tool between the oncology team and the rest of the team, specifically primary care, so that the primary care provider knows like what the surveillance follow-up plan looks like, what we're going to be doing, et cetera. Yeah. Of course.
I just wanted to add what I try to do in the UCSF ran by me survivorship program is have a standard survey and try to send those out prior to my visits. Now it's really challenging because the visits are not scheduled by us or me, they're scheduled by our practice coordinators, and oftentimes it's either forgotten, the wrong questionnaire gets attached. So I can't even tell you how many times my bladder cancer patients are getting questions about their prostate or prostate function or whatnot, and oftentimes I'm finding myself apologizing for inappropriate questions going out to the wrong patient. So to me, pulling the data individually for those visits so I can actually target what they are really worried about is important. But also, and I think it might be more in academic centers, at UCSF we actually have a cancer survivorship wellness program, and I don't know, I'm part of the Survivorship Task Force within a cancer center, but the program offers group meetings, and each session offers, topics from nutrition to sexual health to whatever. So it's not bladder cancer specific, as Mary said, some of it exists individually, and then on top of it, we try to do the individualized bladder cancer plans.
Thank you. Oh, no one wants to see me on that screen. This is enough. Okay. All right. So this was just a basic, who do you see in your clinics if you have one, non-muscle invasive, muscle invasive, advanced disease, or a combo. And most people said patients had a muscle invasive bladder cancer. And then ranking the treatments the patients in your clinic have received from least to most common. So you see not a huge surprise here with almost a tie for intravesical neoadjuvant chemo and radical cystectomy. If you share the care plan with other members of the team, who do you share it with? So a lot of urologists answered that they shared with the medical oncologist, so we like that, right, working together. Primary care providers, a lot of non-urology people said they shared with the urologist. So, we're all getting along. We're just all kind of doing it a little bit differently. All right, so that's the provider data. Any questions about that? Any surprises? Yes, ma'am.
I think one barrier is we're all on different systems.
Yeah.
And so
Yes.
that's always an issue.
Yes.
They might get their neoadjuvant chemo at an outside hospital, and they come back to Bayville for their surgery, but there's that communication is hard.
That's right.
Primary care is a local provider.
That's right. I have emails out to Epic too. No one's going to respond to me, but email all the people. But that is absolutely a huge barrier. It's I complain about things all the time with there's blessings and curses that come along with these things. But I think the goal of these EMRs was so that we could all connect, and it's not a thing that exists in reality quite yet. But thank you. Yes, it's a huge barrier. All right. What did our awesome patients have to say? So our first couple of questions were just kind of tell us a little bit about yourself. So you can see that most people who answered had an experience with non-muscle invasive bladder cancer. 48 people had muscle invasive. 5 people had metastatic disease, and there were 6 folks who weren't exactly sure. The mean age for folks who answered the survey was 64 years old, which is also not surprising. The majority of our respondents were men, but we had some ladies in there as well. We asked folks when they were diagnosed with bladder cancer, so that ranged all the way back to I was going to say, what was I about to say? It doesn't matter. Anyway, 1997 all the way up until last year, and kind of everything in between. So we had a wide range of people who have been living with bladder cancer as part of their experience for years and years and years, or very recently. Where do you receive your cancer care? A lot of folks went to academic medical centers. There were 31 people who got treated at local community practices, and then there were folks who said they got treated at both, which is something that we certainly see, at least in my personal experience at UNC. People will get their neoadjuvant chemotherapy locally because it's closer and easier, and standard of care, a neoadjuvant chemo is pretty straightforward, and then we'll come back to UNC to have their cystectomy. So wasn't terribly surprised by that answer. Then, how far away do you live from your treatment center? We want to know how far folks are going. So for people who answered in distance, it was all the way from 1 mile was the closest. I was like, that's pretty darn convenient. And then one person, 793 miles. That's very, very far. And those who answered in time, the closest was 5 minutes away from their treatment center, and the longest time chunk was 3 hours.
Can I ask you a quick question?
Of course.
On the slide before, you asked about, so do you think people, like, if you go to large group practice, that can feel very academic? Are those like the way that people really think about it?
That's a very good question. Yeah, so do we have a mic for folks? So I think if I understand the question, like a large urology practice, sometimes with a bunch of urologists, sometimes that can feel like academic.
Well, and also community, there's different levels of community,
That's right.
There's a community in a hospital, there's a large urology group practice, there's 10 people together. You can have a clinical study through a LUGPA practice. So I just wondered if people, how you think of it, especially with the going back and forth, right? Because you might go to an academic for your second opinion and then be somewhere else.
Yeah, that's very true. You know, in thinking about how I worded this question, I should have been more specific about like defining what academic actually means, right? Because people may not have kind of known exactly what we meant by that. That's a good point. Thank you for that. Yeah, because there are itty bitty little community practices, and there are very large community practices that can feel like big academic medical centers. So thank you for that insight. Oh, there I am again. Good Lord. All right. So we wanted to know, so we're looking for barriers here too, right? So for those who, and almost no patients skipped questions, which you guys are the best. Is distance a hardship for you? So the vast majority of people, 80% said no, the distance was not a hardship, but that 20% is not insignificant. It's not insignificant at all. Right? So starting to think about barriers and things that we can think about for post-treatment surveillance.
So about the barriers as far as distance is concerned, what it's very anecdotal, gathering data.
Becky, can you take the mic? Do you mind? Thank you.
Okay, so what I was saying was just anecdotally looking at my patients, I find that my patients in particular coming to Baylor are more likely to travel large distances for their intravesical treatment than they are for their systemic treatment. So a lot of times we will find patients who are willing to drive 4 hours for their weekly BCG, but when it comes to their systemic chemotherapy, they're more likely to find care close to home. even though they will continue to come and, follow up with us and get their surgical care with us, the medical oncology happens closer to home.
Do you think that people with non-muscle invasive bladder cancer kind of have to travel to academic medical centers because the lack of BCG being given by community urologists? That's just a theory.
So I think that's part of it, as well as the the side effect profile as well.
Right.
I think that has a lot to do with it. When you're getting your BCG, you might have a little dysuria, and it's okay, you can drive with that. But when you're getting your systemic medications, you just feel awful, and you just you can't drive, so you have to find a driver or whatever, that kind of transportation. But I definitely think that there is a difference between the intravesical treatment and then the systemic treatment as far as distance burden.
That's a very interesting observation. Thank you for that. All right. Back to slides. Okay, so have you ever smoked cigarettes? So 134 people answered. It was kind of a tie. It was kind of a tie there, right? How about that? Current smoker was really small. Yes. If you still smoke, are you interested in learning more about quitting? I mean, I think I appreciate the honesty, right? We can identify this as something that we can help people with. This is why we're doing these surveys, right? Appreciate the honesty. Yes. Yep. And those are probably the people who are not currently smoking, right? Because it says, if you were still, right? Yeah. That could be a little bit skewed too, but still something that we can work on, because there's another, you'll see in the patient survey, there's another thing that kind of stood out to me about smoking, which I think is the next slide. Does your cancer center offer resources or counseling to help with quitting smoking? Over 70% said they didn't know. That's mind-boggling to me, and that is on us, right? Mind-boggling to me. Anyway, so some people said yes, some people said no, definitely not, but the majority of people said they didn't know if there were smoking cessation resources available at their cancer institution, which is not okay. All right, keep pushing the wrong buttons. This is kind of long, but at any point in your cancer experience, have you experienced financial hardship? Most people said no, but what is that, 10, 11, 12% of folks said, yeah, they had. Again, anything above zero is not insignificant, right? Something else we could potentially dive into. Does your cancer team offer telehealth visits? Yes. Those of you who are patients in the room, does your cancer center offer telehealth visits? Yeah? Do providers here still doing telehealth visits, even with some of the potential barriers that are coming down the pike? Okay, good.
Can I ask how many, though, are moving toward not doing them?
We are going to fight that until our fists are bloody. So, yeah, because it would be an enormous patient and provider dissatisfier, because the telehealth, yes, I know there's barriers there because not everyone has access to internet and smartphone and tablet. We appreciate those barriers. And for the transportation barrier and time and having to take off work, it can be a lifesaver. Of course, if people are having acute issues, they need to come in, right? But if it's relatively routine and everything's going well, and we have people who get their scans locally, and we just make it work. Yeah, do you want me to start having chest pain up here? I know you guys can help. No, I'm just messing with you. But yes.
I think a big problem with the telehealth partially has to do with the licensing per state. Yeah. So, for example, I'm in Chicago, right on the border of Indiana, University of Chicago, and Indiana recently changed it where a provider needs to get a separate license there. So we can't do telehealth with Indiana patients unless they physically drive to our facility. But I know that other states, I think like Zach, you were saying, as long as the patient is like established with the hospital, then you can continue to do it virtually. So it's kind of state by state. I think a lot of it also has to do with like Indiana wants to make more money, so they want all these providers to get separate licenses there to continue telehealth.
Michigan's the same way. We can only see patients if they're in Michigan.
Right.
Same in North Carolina, yeah.
It's the same thing in Texas.
Yeah.
And what we do is we'll tell our Louisiana patients to drive to the border, but I also do let them
That
know
counts.
that, well, I also let them know that nobody is GPS tracking them either.
Off the record, of course.
But, you know, are you in Texas? Sure am.
Yep.
Yeah. One thing I wanted to add to this, and I know Jim Scott knows this, and other people who were part of Beacon's visit to Capitol Hill, is
Yes.
that one of our three main asks was for Congress to, allow continuance of telehealth. What I would add to this is that I would suggest that we, as a task force, come up with a recommendation to Beacon Board and the government affairs part, that we go beyond just asking Congress to allow telehealth to keep going, and to ask Congress to pass something that would get rid of these problems, state by state. That perhaps there be a national certification or something like that, because that could help out, considerably, since telehealth is so important to all of us.
Thank you, Bob.
Go beyond where it is now, so that practitioners are properly compensated for that, and their support teams as well.
Yeah. Thanks for that perspective, y'all, and for not only advocating for yourselves, but putting in a good word for us too. We appreciate you. Yeah, that's a huge issue. All right. We wrote just kind of a list of what things are available at your cancer institution or where you received your cancer care. Decent amount of stuff, so nutrition services, but there was also, I don't know what resources are available at my cancer institution, right? So that, not the bottom green, but I don't know what color that is. Gray, which is on brand for I don't know, it's very gray. But, lots of ostomy nurses, to my ostomy nurse colleagues. So I wanted to get a sense of what's available. We have this, again, I can pull this, like all this data from the spreadsheets about like where folks are who answer the specific questions. But I don't love the I don't know what resources are available to me at my cancer center. I think there's a lot of reasons for that. I think, especially at initial visits, like people are bombarded. We think as providers that we do a much better job of explaining the resources than we do. I am very guilty of that. So that was interesting. At any point in your cancer experience, were you informed of any bladder cancer support groups? A lot of people were informed about bladder cancer support groups. I love that. There were a decent chunk of people who weren't, and there were some folks who just don't remember if they were or not. And that's okay. I don't remember what I had for breakfast, so. Right, went virtual, yeah. Have you ever participated in a bladder cancer support group, either in person or online? Lots of people had. This made me very happy. I love that. With the caveat that support groups are not for everyone, right? Some people just don't feel like they need that extra layer of support, or it's not for them, and that's okay. What we do at UNC, our support group is independent of our institution. It's run by patients and caregivers. And I let them know that it exists and how to get in touch with folks, and then they make the decision as to whether or not they want to join. Because that's a very personal experience from what people have told me. We wanted to know about online groups. So there's a lot of Facebook stuff. There's things on Inspire that I know many of you are interested in that are like bladder cancer specific. Lots of folks had, which is good. And then we asked a few questions about, is there a survivorship program at your cancer center, and went on to kind of define what that looks like. Most people didn't know. Some people said, nope, absolutely not. And there were a decent number of folks that said, yes. Have you ever received care at a survivorship clinic? Big fat no. Nope. Handful of yes, and again, I don't remember is also acceptable. I think that, how do I put this? Something that is just not, if it's not well defined and explained to people, then it makes total sense why people would say, even if they did get care in like a bladder cancer survivorship clinic, that they would say no. Like if it's not well defined, then how are people knowing they're getting that kind of tailored care? Okay, so we had some takeaways as a group based on our survey data. So from the provider perspective, that a lot of providers are interested in bladder cancer survivorship clinics, and that there were a lot of potential benefits that were identified, and that there were a bazillion barriers that were identified. These barriers, time, funding, and staffing are similar for the barriers we have for every aspect of healthcare, unfortunately. And also that advanced practice providers play a key role. And this was recognized not only by the APPs who filled out the survey, but by our physician colleagues who work with APPs, recognized that our role in this important part of patients' care. And from the patient survey, that a large percentage of people didn't know about resources at their center, 40% of folks, including smoking cessation. People really like access to telehealth, and a majority of people had access to telehealth. Most patients were not sure about the availability of bladder cancer survivorship clinics at their facility, and a lot of folks had participated in support groups, whether in person and online, so getting extra support outside of the cancer institution. All right. Any questions for me before we kind of go on to next steps? We have an hour and 2 minutes officially left. I'm going to get some water while you all question your life's choices about coming to this session with me. Please.
So when you sent the data to the patients, what other demographic information did you collect as far as like income, race, or state? I'm just curious.
None of that. None of that.
And the reason why I was asking, because it can kind of correlate to the availability of resources.
I agree with that wholeheartedly.
Because even now that I've become more involved with Beacon, is the patients who access Beacon tend to have more resources versus those who do not.
Yes.
When I did my study a year ago, the majority of thank you. I didn't really need a mic. But the majority of the patients that I interviewed, their incomes were $150K plus,
Right.
and they were connected to me through Beacon. So I think that's one area that we can continue to look into, especially as we start to explore this disparities in healthcare and bladder cancer treatment, and how we can move forward in those next steps.
That is an excellent point. And I think part of what, one of the points I'm pointing to this, like you can see what I'm pointing to. I'm sorry, y'all. More focused surveys, because I think, and again, like I want to do all the things, but I think something that is huge, not only in like the general umbrella of cancer care, and then like the little sub umbrella of bladder cancer care, and then the sub umbrella of bladder cancer survivorship care, is this enormous topic of healthcare disparities and what that looks like as far as how it's affected by race and income, distance, where people live, caregiver support. Obviously, that is enormous. But I think if we can, over, I'm going to say years, because realistic goals here, come up with more tailored surveys to get some data like that would be absolutely crucial. And I know that you touched on this so much more eloquently than I ever could, and that it's just, it's a huge issue. I work at UNC, and we're the state hospital, and there's tremendous social barriers to care.
Exactly.
So thank you for bringing that point up.
Well, and then, since we're at the think tank, I'm from Houston, Texas as well. I'm at MD Anderson. I'm actually a little embarrassed, or very embarrassed, that as us being the #1 cancer institute or whatever, that we don't reach out more to the greater, Texas area. Texas is huge, and we have so many patients who don't have access to the Texas Medical Center. And then what are we doing as the #1 cancer center to reach out to these communities to make sure that they have access to these resources? So BCAN can probably be a beacon of light as far as spreading the word and helping us facilitate that, these resources and getting them more involved. So that's why I'm here. So I could talk about this all day.
This
I'll pass
is
the
wonderful,
mic.
and that's kind of like one of the broad things that we were thinking about as far as next steps based on the survey data is not necessarily something that's easy, but like a relatively simple like launching point of, all of us here obviously are pretty darn good about getting our patients the information that they need through Beacon, but creating more of a post-treatment survivorship or just general survivorship space, dedicated space on Beacon's website. I've already been told that I can do that. Sometimes I have to ask for permission or forgiveness, but on this instance, I did ask permission, and this is a thing that is doable. So having just like a big tab that says survivorship, and then so much information that we can put in there to direct people to. So there's already existing resources through Beacon, but putting them all in that one space. We don't have to recreate every wheel. We're not here for that. Like, I'm not asking that. But just to put the existing stuff that is specific to survivorship care in a place instead of 17 different places, right? A bunch of clicks that people don't want to do. And some information that we as a group can live there. Incorporating some needs from the 2022 survey to making sure we're continuing to address that. Information for patients and caregivers. And I think it's really important to highlight having information for healthcare providers about survivorship, right? Because I think there's, as evidenced by the PubMed search, there's not a lot of data out there. And if we can also house some information for providers, such as care plans, or this is, the way that UCSF does it, like not reinventing the wheel or telling people how to run things at their own institutions, but having examples so people can have a place to go to and say, and maybe contact information for the queen of West Coast survivorship over here for questions. There's a lot of things we can do with this space. And then how to disseminate this information. So maybe it was your idea, or it was someone on the call who said, great, if we create this space, how do we get people to know about it? Because that's part of the problem, is like getting people to know that it's there. When, I don't know if you all went to the main Beacon page like during walk season, but when you went to the main Beacon page during walk season, there was like a pop-up, right? I think that was, that you, Karen. There's a pop-up where it said, it's walk season, go to the link to register your team. For reasons that are unclear, my face was on there a few times. So you and I are gonna have to have a chat, miss. It's like, no one, I mean, it was a decent picture. I would have called you if it was not a good picture. Yeah, I was like, this is a good one. But just like for a defined period of time, I don't know what that would look like, but you go to the main Beacon web page and you get that pop-up that says new content about, survivorship care and bladder cancer, and click it and you go. So that way people start to know that it's there. So that was a great idea from Karen about the pop-up thing. Yes, ma'am. Please.
So some of what I kind of know is possible, I'm not making any promises, but if there are other pages within Beacon that someone might visit that you think would be beneficial, then let them know about survivorship. You can actually put pop-ups of individual pages. Then at a few different times, based on where people go. So that's another consideration.
That's cool. I can barely run this PowerPoint, much less like figure out how to do that. So that's it. That's impressive. That's how we have Mark.
Mary, we have a
Yes, I'm sorry. Yes.
Oh, sorry.
Hi. No, please.
I was just gonna. Hi.
Oh, I keep like shouting out UCSF, and I didn't even know.
Well, I was going to apologize first whenever I talk about our own field, because you had one question on financial impact of cancer care, and I would argue I'm not sure even academic centers know how many patients overall are dealing with financial problems, transportation burdens, food insecurity.
Absolutely.
So when it comes to specialized focused care for bladder cancer, I'd say it's equally bad everywhere.
Yes.
No matter, I mean, I talk with Heather often. Like where I grew up in Houston, where I work in San Francisco, there are people within walking distance who don't have access to care. So I'm not sure it's truly a distance, but it is a real barrier from a structural standpoint.
Thank you so
I
much
think-
for that.
And this is why I always argue some of these solutions will be more local. It just, we're not comfortable looking in our own backyard at
That's
some
right.
of the things that are happening. So that's where kind of my question about which programs actually have more than one person doing everything with no funding or support.
Yes.
And I would say that Beacon has been instrumental in things. I got the okay to talk about it. Now that they are partnering with community cancer centers to offer or work towards targeted site-specific solutions to disparities in bladder cancer. So that is happening. That's coming down the pike.
But it also is, we have to ask our patients.
Correct.
It sort of boils down to you have to ask.
Yeah.
If this is going to be a financial issue, tell me so that I can help you find the resources.
Yeah.
This just has to be part of what we're doing with our patients.
Yeah.
I think sometimes that gets written right
Yeah.
across and completely forgotten because we have bladder cancer, we're trying to deal with the bladder cancer.
I think, thank you, all of you, for that feedback. If Beacon, if you can hear me, if you can fund every single bladder cancer institution with at least 10 social workers, that would be fabulous. Thank you. I don't ask for much, but I think, I think where things fall through the cracks is that I'd like to think that I can do all the things for all of my patients. I cannot. I can do a lot. I can't do it all. And I think that our social work colleagues are stretched very thin. I don't, Karen, I think I was talking to you about her, maybe Krisztina. I don't know. I talk to so many people. I think in our outpatient cancer center, which is a comprehensive cancer center, we have like 2.5 social workers, which is absolutely bananas, right? So I think if we had, if we were able to have more of our partners who are experts in helping people who have these transportation barriers or access barriers, financial barriers, childcare barriers, like all of the above, all the things that you all know about, I think can make a huge impact, not only during active treatment, but in post-treatment surveillance too. I get a lot of folks who unfortunately, like during surveillance, post-treatment survivorship, just kind of fall off the map because it's like, okay, my treatment's done and there were all these barriers, and sometimes people don't see that post-treatment surveillance being as equally as important as the active treatment was. So these are, like, y'all's insight into this is huge, and thank you for your feedback, and thank you, Rebecca, for getting us all social workers. Appreciate it.
Well, I'd like to mention that, this year one of our new initiatives is call center with cancer care, so which is direct access to social workers, and so that's something that we have been seeing success with people contacting. So that is one way that we're trying to get people more access to social workers. So there is information on that in your program. So I definitely recommend, especially as providers, to offer that up to your patients.
Thank you.
And one more thing.
Please.
What I would find interesting or beneficial is how many of those patients were told about Beacon
when they were, by their physicians. Why are you taking a picture?
Thank you. I'm trying to write and talk at the same time. That doesn't work.
Oh, hi.
Okay.
Hey, I have a question
Yes, go ahead.
I have two questions actually, and it's for the providers and for the patients. So the first question is, for the intravesical therapy, do you guys have your patients ring the bell? No. So our patients ring the bell. And, when you think about it, of course it's, the systemic therapy is kind of, I don't want to say far more life-altering, but it has a potential to be that way with like hair loss and those types of things. And I think sometimes people will think, oh, well, you're just getting the medicine in your bladder. It's not that big of a deal. But when you think about specifically like BCG patients, that's a 3-year commitment that they have. And I've found that they are so tremendously appreciative of that opportunity. And if you would see the sad bell that we have, like old school bell, it's got the little black handle and it goes tinky 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 tink. But the patients appreciate that so much, and everybody in the clinic stops when somebody rings the bell, and everybody comes out, and the patients really appreciate that. And I've been trying to get donors to buy me a real brass bell, but Dr. Lerner doesn't want the research money to go to the bell. He wants it to go to his research, so I have to do it on the down low. I'm working on that. The second question is, do you guys have a patient referral list? So, for example, I know you can go to the Beacon website and talk or chat with people with similar diagnoses and stuff like that, but we have a list of patients who are willing to talk to patients in the area, and we have a little consent form and everything. Does anybody else do that on a local level? You do?
I have an
Okay.
informal list, yeah.
Okay. Okay.
I'm going to change the subject here, but just a couple of ideas for maybe quick and easy things that we
Yeah,
could do as a task force.
Could we pull the slides back up for a second just to see how much? Yeah, that'd be great.
Oh, sorry.
No, it's okay. I think I hit all these highlights. If you give me just a second, Bob.
Sure.
So prioritizing action items. So I know that Beacon is partnering with cancer centers, so academic and community, for some qualitative research that I think we could probably investigate. Looking into what does a model of bladder cancer survivorship clinic look like? There are some folks who couldn't be here today who have sent me some really interesting stuff. I got some stuff from Sloan Kettering about their survivorship model. So again, not recreating the wheel. So thinking about just what could a standard of care look like, with the understanding that that has to be tweaked per institution, more focused surveys like we talked about, and then putting together a listserv, which if anyone is interested in being on that, please come up and scribble your email for me, with the understanding that that will in no way be abused. It will not be a daily email. It will be a, hey, it's time for our quarterly meeting. Please join us. And you can email me separately with questions and concerns so that not everyone gets blasted. But I think it's really important for the people who are interested in taking the next steps to stay connected, because we have a whole year gap. And I think that would be a good idea. So Bob, if you want to give us your thoughts, I'm certainly ready to hear them, and then we'll talk about
Sure.
what sounds good.
Sure. This is feeding off of what Rebecca was saying about the call center. A simple thing for us to do would be to have our task force interact with those clinical social workers, and make sure that they're aware of what we're doing as a task force and what Beacon is doing based on what our task force is recommending, so that they can point to the resources that we're going to be highlighting through the web page and so on.
I love that.
Another one is, again, this will be based on what Beacon is already doing in terms of presenting stories that people are telling. Why not have success stories that we can build based on patients who have had successful interactions with a survivorship clinic or groups, and have a series of those appear on the website. And then the last thing, one thing I was really struck by was hearing folks here talking about the difficulty of the sharing of data, the sharing of experiences, and the sharing of scheduling. With Epic, some hospitals have it, some don't. There's different systems out there. I just wonder if it would be worthwhile having our task force, again, give a recommendation maybe to the BCAN board to do something, and I'm not sure what that is, towards improving the communications between providers. And I realize that that's a much grander initiative, but that's a hurdle that is causing some real problems. So I don't know where that would go to, and if we even want to tackle it. But
You're making my chest pain come back, Bob.
yeah, my wife is actually working for our daughter-in-law's lung clinic, and this thing of scheduling is such a big problem. It's really incredible.
Yeah.
And so if reminders are not going out when they should be going out, if they're not being shared from one institution to another, where the patients are being seen by multiple locations and multiple institutions, I think that's a huge problem. It
is a huge problem, and I think that's something we can certainly highlight on here are some things we need to be mindful of as providers in the post-treatment survivorship phase, fixing all of those issues that turn my hair gray. I don't know that that's within kind of the scope of what we can do, but at least bringing it to the surface and reminding people of the importance of that communication, especially when people are getting treated at different institutions. Completely agree with that. Thanks, Bob. We have a microphone back here. Hi.
Hi. So back on the subject of social workers and the call center, to kind of tie into the support groups, I think BCAN does a great job of rallying the S2S team of volunteers on this call center. But I think I started a support group for Indiana pouch people 3 months ago. And if you network with me, you'll get sick of me talking about how, Karen already knows this, how the Indiana pouch is the greatest invention in modern medicine. But I thought I was going to be really great at leading a support group because I just retired from corporate America, and I realized quickly that this is a whole different thing.
Yeah.
And I was looking for resources on being a patient-led support group leader. There's one good thing from University of Kentucky out there, and there's nothing else I can find. But it also made me think, there are support groups out there that could be talking about the call center. Like, we have these patient-led support groups that we could be rallying all these leaders, A, to get people to BCAN, B, to talk about the call center line, and whatever survivorship programs this task force is going to do. And I've been thinking about, how do we pull these support group leaders together? How do we create a network? So I'm out on my email starting to introduce myself to people, going, I'm Sandy, I'd like to meet you. But it seems like, and we also have people that are BCAN people who are out in the Facebook groups talking about BCAN. And I think that's another way I think we need to figure out how to tell the BCAN story so that people who are in the Facebook groups, that they're like, I don't want an organization, I want to hear your story. So what I quickly realized is, I have to tell my BCAN story. I have to say, BCAN helped me. BCAN was started by survivors, not just put the BCAN site out there. That can turn people off. So I think there's a lot of opportunity in how we can get those people to BCAN that we're all talking about that don't know about it. And I've been treated at 3 institutions, and it wasn't till I just got to Weill Cornell a year ago that I got introduced to Beacon. So I was 6 years into my journey, and the other 2 were big academic organizations. So lots of opportunity.
We have been talking, this is my 10th think tank, and we have been talking about that since I've been coming to think tank. Like, why doesn't everyone know about Beacon?
It would seem like if you could somehow, as far as the groups, get a Zoom of the community leaders that are doing these groups, you could share, hey, this is what our group is doing. Even if it was like a quarterly meeting, where you shared that with and then you have a whole network that you could do across the United States plus.
And share ideas for speakers and how do you facilitate.
I don't know who has access to the support group information. Do you all? I mean, because I have one. So maybe.
Somebody has lets us know that they're in the support group. We do have a list.
Okay. So it.
Yes, to your point, it's a list for people to contact.
Okay. So maybe, and just kind of thinking here, and then I promise I will let you come over, is maybe that can be, so that the support group task force can be a separate thing, and then we, like the leaders of this task force and that task force, can come together to collaborate. Does that feel okay, or does that feel like I'm pushing work on you? Does that feel okay?
Yeah. Is there an existing support group task force?
Not that I'm aware of.
There is now.
And honestly, like, I think, and just kind of talking to my patients and folks who are in our support group, sometimes patients and caregivers prefer when the healthcare providers are not lingering in the background giving their opinions on how to run support groups. So I'm happy to have that be led, and then we can connect. Does that feel okay?
And I will say,
Ma'am?
if anyone is part of support groups, if you have a chance to go on BCAN support groups, and just make sure if your information is not up to date, just let me know, or any one of us, and we can make sure that we have that as up to date as possible. You just need to let us know. Because I know some things change.
Just wanted to add one quick thing to that. At UCSF, we do have a California, so it's not UCSF specific, it's run by UCSF, social work. But anybody who consents, basically from any part of the country, can join these visits. They're all currently done via Zoom. I do really like the fact that people are invited. So as you said, different people can present, or presenters can be shared, and it absolutely goes through the entire spectrum of bladder cancer care, whether that's immunotherapy, that is, what's going on currently, to nutrition, to sexual health. So there's always a speaker every month, and these meetings currently really happen once a month through the university. And the other thing I wanted to share regarding spreading information or resources, I was able to help 2 of our fantastic nurses in urology to get to their clinical nurse 3 level, which is the highest level they can practice. And that was partially driven by my own selfish need of not being the survivorship clinic. I needed materials and I needed help. So my colleagues Sarah Kuna and Jessica Creedon, they have developed, with oversight from me and Dr. Porton and a few of us, a very comprehensive bladder cancer material. So we have a comprehensive video that is about 30 minutes long, pre-cystectomy, touching on everything, a 23-page PDF file. And I officially can't share this because I got into trouble with the university. But I was allowed, forgiveness, I know. Yeah. But officially I was allowed to collect anybody's name and information institution, so it's undergoing review for us to share it publicly or through BCAN. But I understand it's probably the most comprehensive material out there. It took us a very long time to develop it, but it's up and running. The material is shared with patients pre-cystectomy before meeting me prior to surgery, and they are quote required to overlook this, and they usually get it about a month prior to either their surgery date or their visit with me, along with getting the ostomy kits that I was talking to Karen about. I'm in touch with Hollister and Coloplast. So everybody gets all the material pre-meeting, and then we launch into the discussion of diversions. But if anybody's interested, we are going to have a second list next to Mary's list about that.
Getting it done in San Francisco. All right. So, like I said, Beacon has a lot of resources already. So I think there's some content that we can create, and I think that there is definitely content that we can pull to kind of pull into this survivorship specific part of the Beacon website. We are currently, again, like getting information from UCSF. I got some emails from Sloan Kettering about their specific survivorship program, so that we can then kind of pull some of that information and over the next year discuss what other places are doing, what makes sense in the context of post-treatment survivorship for patients who've had a bladder cancer experience, and then potentially make recommendations and, you know, write a paper for this. Other cancer-specific organizations likely have materials that I can spy on as well. So, you know, breast cancer, I'm sure, does this well. And then, you know, setting realistic expectations for what the next year is going to look like. So these are just the tip of the iceberg for existing Beacon resources, which can be very easily found on the website. And these are some ongoing discussion topics. So I kind of touched on, do we have anything to use as a model? And that information is coming through because I sent out a plea. So we are getting that information. So that's one thing we're working on, kind of defining what bladder cancer survivorship care is. And then authoring some Beacon-specific vetted survivorship guidelines. So again, beyond the intervals and diagnostics that are done post-treatment, but incorporating other aspects of survivorship care into what those clinic visits should look like. Yes, ma'am.
So have you ever thought about having, like you said, that there's a gap between people doing a follow-up?
Thank you. So in that gap, have you ever thought of something that patients could actually say, I need to make sure I've got a cystoscopy scheduled every 3 months, like a calendar you can load down, something like that?
Can you repeat the first part of your question? I'm sorry.
So given that patients often have to drive their own treatment and scheduling, in those guidelines, could there be like an app or a calendar people could download? I know when I had to schedule CT scans, I scheduled every single one. I was never called to say, schedule this in 3 months, right? So, and if you have to have a cystoscopy, it's easy to let it slip to 4 months or 5 months because you don't want to go and do it.
Yeah. I'm so sorry you had that experience with that.
It could be different in different, you know.
I may have been hallucinating last night or just misremembering. Is there some sort of app that's being created right now through Beacon? Okay. Do you know who I can talk to about that? Mark? Okay. Because incorporating like scheduling reminders. So unfortunately, sometimes like the ball ends up in the patient's court, always. So maybe having as a part of an app, some scheduling reminders to yourself, I think is a really great idea. Yeah. Thank you. Yes.
I mean, for Epic at least, like my chart, like for our patients, so they'll get a cystoscopy. We'll say, okay, you're going to come back in 3 months. So on the way out, checking out, they'll schedule another one in 3 months. Obviously, pending on what the cytology comes back, if we didn't find a tumor. And then, assuming you have, you know, my chart and you download the app, it's on your phone. You should be getting reminders, like a few reminders prior to the appointment. You get emails, you get calls. A lot of it's automated too. So, I mean, that is a reminder.
Sounds like some of that's like slipping through the cracks depending on institution. Yeah. Yes, sir.
Mary, I have a question. About 4 years ago, I went through the UNC system. I still am. You had an app, and after my surgery, it checked in with me every single day for a very long period of time. You know, I think it was 4 to 6 weeks. But then I never heard anything else about that. So what happened to that? Because it was such a fabulous program. Not only for, it was, you know, kind of like telehealth medicine, but not really, because it was an app.
Symptom driven.
Yes, but yes, Mary, yes. It was symptom driven, and it asked you specific questions. And if you answered a question a certain way, within 5 minutes, you were getting a call.
Yeah.
To discuss that.
Did you enroll in the clinical trial with
Yes,
that?
I enrolled in that clinical trial that
Yeah.
we had going on there.
Yep.
Yes, ma'am. And I always wondered what happened to it, why it never...
This really does full circle back to the discussion about why does the clinical trial data just like go into the universe and patients don't know what happens to it? Because I remember that, and patients, we have a similar thing going on with metastatic kidney cancer, where it's basically like patient-reported outcomes, and we get emails, we get flagged if there's something, you know, going on with them, and like within 30 minutes they're supposed to get a call. So I know what you're talking about, and I think it's a fantastic tool, and I know who I can talk to about that. So to be determined. Thank you for bringing that up.
So one of the things I want to talk about, you know, she was discussing how, you know, the clinic didn't reach out to her to remind her. So one of the things I've been working with Stephanie for a couple of years, we've talked about this, but this fall we're planning on putting together a webinar about kind of like patient etiquette or patient responsibilities, so that they understand that they're not just sitting there and waiting for somebody to call them to make their appointment. Number one. The other thing is also educating them about the fact, like, what is a prior authorization, and what does it mean when you get that letter that said you've been denied for your CT scan. So many of our patients that have AM better, which in my opinion is the AM worse, but you know, they get like standard of care. They're refusing standard of care. It's absolutely ridiculous, and I think it's just a tactic to get people to give up. And that's what happens a lot of times, is these patients just give up. Oh, okay, my insurance didn't approve it, so I mean, I can't afford this $4,000, you know, PET scan that my doctor wants me to get. So part of the education we want to give the patients this fall is the fact that no, we don't stop there. And you may need to, you know, reach out to the clinic and give a little nudge, especially in the healthcare environment that we have right now. I can speak for myself, and I promise you that if all of you have the same experience, is, you know, I'm one person quite genuinely doing the job of three. And things, you know, slip my mind, and I don't get to do all of the things that I really, really want to do and I intend to do. But getting the patients to understand, you really have to take responsibility for your own health. You can't put that responsibility on me, because God knows I want you to be as healthy as you possibly can, but I have 200-300 other patients that I'm having to think about, and you know, we have to take my whole personal life out of the equation, you know, that's going on at the same time. So just kind of really empowering patients to take responsibility for their own health and being their own advocate, so advocating for themselves. But that's one of the things that I am working on with Stephanie, and we're going to do a webinar this fall. If anybody has any information that, you know, they would want to put in there, oh, go right ahead, sir.
As a little aside while we're passing the mic, something that I put, and I don't know, Krisztina, if you do something similar, something that because I'm in 2 clinics, so I'm in clinic 4 days a week. One of my clinic spaces, people check out with an actual human being and get their appointments. My other clinic space, it's someone will be in touch. That makes me absolutely loony. So I have when I give people their after visit summaries, which everyone gets an after visit summary regardless, and I'll print them if there's no one there to help me. Part of what's on the after visit summary is, if you don't hear about scheduling your next appointment within the next 7 to 10 days, please call this number. Because stuff does get missed, and it's not okay. So.
Well, the point that was being made before, from a patient's perspective, when you're looking for the patient to go back to whomever the doctor is, primary care or a specialist, for an authorization, well, if the doctor put an inappropriate procedure code on the authorization, how in the world is the patient supposed to know, how do I get this thing approved? And it's all delay, like you said. Insurance companies don't care. We hope you go away. But it's delay. And it's really, it is so sad. I mean, really sad, because we're talking about people's health. But how can we put that back on the patient? Patient doesn't know the procedure codes. They don't know them.
So the patient can be empowered to reach out, back out to us. And that's what they need to know, that it's just not the end of the road when they get that letter in the mail that says that it hasn't been approved. That's their trigger to say, I need to call the clinic, okay, and talk to Becky. Hey, Becky, I got this letter that says that my CT wasn't approved. And I go, okay, no problem. Let me get on Evercore, or let me call Humana or whatever, and we'll get this approved. Because I can say, and I don't know about anybody else, but I have never had one of Dr. Lerner's peer-to-peers denied. So it goes to peer-to-peer.
Yeah.
And it almost always, or at least in his case, it gets approved. So there are ways and there are steps. And one of the things that you talk about delays, I had a patient say something to me the other day, and she goes, I just feel like I am being 2 weeks to death. Oh. We'll get you an appointment in 2 weeks. Okay, your CT scan will happen in 2 weeks. Well, that get declined. Well, it's going to be another 2 weeks. And that I do see that happening a lot with the patients, and it can be very disheartening to them, because 2 weeks becomes 2 months, becomes, even all summer. And it's really sad, and it's difficult in the healthcare environment that we're in now. You just don't have enough people to do all the things that need to be done.
Yeah. Thank you all for this discussion. Just looking through my slides to make sure there wasn't anything else.
But just to
really
follow up on that again.
Touch on. Yep.
Okay, we're talking about patient education, patient knowledge, patients having the wherewithal to follow up. And, I have a very difficult time accepting some of what I've seen here today, because when you don't know the demographics, what was it, 18 million cancer survivors? How many of them are people who are underserved? Not just, people of color, but underserved. And how do we reach them? How do we get them to follow up, when something doesn't go right? It's frustrating. It really is. And I don't think I'm going to live long enough to see it change. But anyway, the other thing I wanted to say is that, we talk about, and God bless you for wanting to start a cancer support group, and particularly with in Indiana Pouch. How many women do you know in your community, not, the nationally or whatever, that's going to join you on a Zoom call? How many do you know in your community? It's not a rhetorical question.
Not many, because, we're the smallest of the diverse.
Right. There's such a small group, and not just with Indiana Pouches. I think if we look at bladder cancer survivors in our own communities, how many do we know? Very few. So now we're talking, a little bit about starting cancer support groups. Why can't we go? There are bladder cancer support groups. There are cancer support groups out there. Is it impossible for us to join these other cancer support groups and bring in bladder cancer awareness? And instead of, again, trying to reinvent the wheel with something that is, such a small population, it's going to be very difficult to do. Can we join some of these existing cancer support groups and bring in bladder cancer awareness.
Are you specifically speaking to like other types of cancers and going to their support groups? Just want to make sure I understand.
I'll give you an example. Gilda's Club. They take children, adults, doesn't matter age or anyone. Doesn't matter what kind of cancer that you have. They take in anyone and everyone who is a cancer survivor, a supporter, whatever.
Yeah.
So these are the type of groups that I'm talking about, that already exist. Why can't we, go to them and say, look, do you have anything here about bladder cancer? Can we bring in materials? Can we do programs? Can we have a one night a month, to have see if we can create a bladder cancer group?
I think my answer to that would be you have to make the ask, right? Like of that, I've never heard of that organization that you mentioned.
Yeah.
Oh, okay. I thought you said something different. I'm sorry. Yes, I have heard of that. So I don't think there's any harm in making the ask, right?
Yeah. Wouldn't that be like a quicker way to get in?
Yeah. Like in response to your suggestion, I was just speaking with Rebecca about the UOAA because it's national, and it does take in, that is a support group. That's what we had. I've been an ostomy nurse a long time, and that's where all the ostomy patients went to, and you're correct. Bladder was there, and we worked with them. So next Saturday, believe it or not, they're having the National Bladder UOAA in Houston, and they have a stoma clinic. I'll be there. And so this is the time that we talk about the various groups, that can also be there. So I will get information to them. I have friends who work with the WAC programs. I just texted them. I said, do you guys discuss BCAN? And she said, yes, we do, Jocelyn, and we'll continue to do that for the new WAC students coming out. We precept and we give that information. So I think there are a lot of avenues and a lot of ways, and I think people are doing that. I just think collaboratively, we don't have that collection. So I think in our own little ways, we're putting that out about BCAN. All of my patients at Methodist, we put that information in there. So I hear what you're saying, and I agree. I just don't think everybody's saying what they're doing. So this would be a great place to deposit everybody we've made contact with, that we're trying to get the word out. So again, like next Saturday, there's an ostomy clinic, and the local WOCNs will all be there. It's from, my day is Saturday, so Thursday, Friday, Saturday, and they have an ostomy clinic. And basically, we're there to support that. But it's a national group. And so that's another, so in reference to what you're saying, there are groups that we could tap into.
Thank you all for the very robust and important discussions. But did someone, oh, sorry, I just want to make sure I wasn't missing a question. I am slightly overwhelmed and just completely humbled by the personal experiences that you all bring, whether you have had a bladder cancer experience, caregiver, healthcare provider, et cetera, because everyone's perspectives here matter. And a lot of people have brought up topics that I haven't thought of. I mean, in survivorship care, there's probably about 1 million things, rabbit holes we could go down, right? So in thinking about that, could I have my slides back? May I have my slides back? Thank you. Thinking about, God bless America, wrong one. So thinking about goals, I intentionally left this slide blank, and I'm going to see if I can this be? Yes. Move this without breaking it. So we have officially, nope, that's incorrect. Incorrect. So we have officially 15 minutes left for our session. So I wanted to talk about what I heard as far as some goals for this year, and then think about narrowing some stuff down, which we can talk about in this space, we can talk about at lunch, we can talk about at our next task force meeting, which will be sometime this fall. To that effect, if you're not on that invite and you would like to be, I'll need your info, so come up here afterwards. But these are some things that I've heard that we talked about over the past year and things that we've talked about today. Creating a survivorship space on the BCAN website. This task force meeting with the social workers who are doing the call centers. I think that's a great idea because I think we can get a lot of information from those folks about what people are calling in with as far as needs. And maybe that can help us with our task force ideas. Creating that listserv, which I promise will not be abused. More tailored surveys, because a lot of what we've talked about today are social barriers to care. And I think if we tailor surveys to those things to get more data about demographics and potential hardships, then that can help with future progress. The app, I'll talk to Mark's story about how we could potentially incorporate survivorship stuff into that. At some point, coming up with surveillance guidelines that highlight the important aspects of post-treatment survivorship care that are not just come back in 3 months for your cystoscopy. There's the big ones that I wrote down. I was trying to write and talk at the same time, but if I missed anything or if anyone wants to add something to that list, or if any of that sounds like a terrible idea, let me know. Yes, please.
Well,
I'm trying to get this over here.
When you say survivorship, I was also thinking, how do we define survivorship, and also how do we define survivorship wellness? What are some of the dietary recommendations or the activity recommendations, or just how to stay healthy in general and how to move forward with that, and then how do you incorporate that into the support groups? Like, you may not be in the same city, but we can arrange virtual walks or something to keep up our general wellness. Because a lot of the patients I see is like, okay, you're cured for cancer, you're done. And then it's like, well, now what? So now we have to continue on that same trajectory to make sure you are able to meet those survivorship guidelines and, continue to lead a healthy and happy life.
You touched on kind of the third bucket that I try and do in my survivorship visits, which is diagnostics, what side effects, and then all the other things, right? That information exists. Wellness after cancer, exercise, nutrition, sleep, smoking cessation, all of that stuff exists, right? So I think finding it, making sure that we can use it and tailor it to BCAN and bladder cancer patients, and having a home for it all in one space, and then figuring out how to disseminate it is a big goal.
Also, again, thinking out loud, so I'm a nurse, and the thing that's coming back in vogue, because if there are any nurses in the room, there are a lot of things that we do, and then it goes out of vogue, and then 10 or 20 years later, it comes back in vogue. So now the nurse navigator position is coming back into focus. Yeah. So for my BCAN people, I would want to just say that the nurse, it doesn't even have to be a nurse navigator, but a navigator type individual could really help to kind of usher you through these different phases of care, and even through survivorship, or you can even have a survivorship navigator to help you, access those different buckets and help guide you through those resources. So just a little hint. And then that navigator could also touch on the social aspects, as well as the different, disease process and so on and so forth. So again, just putting it out there, and we can converse about the whole navigator role position.
Thank you for that. I know that a lot of institutions have nurse navigators. We do. And a lot of institutions utilize their nurse navigators in very, very different ways, in ways that I, as a nursing professional, find incorrect. In a perfect world, we would have more nurse navigators in these important roles to follow patients during treatment and beyond, right? That's a hill I've been climbing for a long time, and I completely agree with you on that. So thank you. If anyone has a good, or I shouldn't say good, but examples of how a well-run nurse navigator program looks like, feel free to, in the interest of time, stick around afterwards or talk to me, because that's something I'm definitely interested in. Yes, ma'am.
I was just going to say, kind of what you're talking about is the patient, at some point, you would want them to transition from survivorship to thrivership. Instead of being the cancer just survivor, I've survived this and it stops, then there's like this transition where you go into the thriver and you do the nutrition type things and the walks and whatever beyond just surviving the diagnosis.
Thank you. Bob?
So Mary, now I'm just going to try to totally overwhelm you.
Thank you.
So just a couple things that we had talked about previously. And one is success stories, getting that onto the
yes,
website.
Yes, that's on my list. Thank you.
Another thing is hearing about the Reminder app. I think it would be great to resurrect that and get that out there for a lot of patients. And when you think of just about everybody has a cell phone. I know that there's still underserved folks that don't, but over time, how many cell phones are there in the U.S. versus the population? It's like, twice as many. So I think that's, something that's definitely worth doing. Another thing is our task force perhaps making recommendations to the BCAN board.
Yes.
Such as regarding telehealth. And we have a board member sitting right next to me here, so. So we have a direct avenue to the board, which is really good. And then in terms of tailored surveys, I think it's more not so much how the surveys are constructed, but how we reach to the underserved populations. And so I think that one thing I think we should consider is that we as a task force have some of us go out and actually talk to the patients in the underserved populations directly. They're underserved because they don't have a cell phone, because they don't have financial access, all sorts of reasons. I think we need to perhaps go out and personally reach out to them. And to me, it's sort of like a 90-10 proposition. I think we'd get 90% of what we want out of the surveys by talking to 10% of the people. I think it's really more so the quality of the conversations than it is the number of people that we talk to.
That's a really great point.
I think you still need to be broad in how you reach out, geographically, whatever. But I think it's important to have us, work personally to do the surveys.
Thank you.
Thanks.
And by the way, I'm overwhelmed in a good way, not in a bad way. This is like filling my soul with, wow, you people are amazing, and I'm so thankful to be able to be a part of this.
I've got the mic.
Sorry. No.
Sorry, Yvonne. I'm Bob Littman,
Hi,
BCAN
Bob.
patient
Good to see
advocate,
you.
and I should be on the mailing list if I'm not. But historically, BCAN did train some of us as a nurse navigator or patient navigator. So this was a long time ago at the BCAN Summit, which was for patients and caregivers and survivors. And it was a large group, and there was a cohort of us that were given training about clinical trials. And we also had access to the Nurse Navigator Training Program. I think it was at GW or maybe Georgetown. GW. So I remember going through all those materials, and it was very interesting. But that's sort of as far as it went. You know, we had access to the materials to learn what it was to be a nurse navigator. So maybe something like that can be resurrected. You know, it was I think the training program was related to breast cancer, but to see what could be done, any information could be gleaned for bladder cancer. I had been thinking of, you know, like shadowing one of them just to see what it was like. But it was a big part of the Beacon Summit in terms of training us and having someone talk to us about what it is to be a nurse navigator.
Thank you. And yes, please remind me to get your email. I don't know why you're not on this. I'm sorry, Bob. Anybody else before we... Okay.
One concern I have is the role of the caregiver, because that's the person who must stay strong as the patient goes through treatments, their ups and downs, their ins and outs, all of the things that they have to endure during and after. And sometimes I think you need a caregiver for the caregiver.
Absolutely.
Because that person can never, I mean, you have to listen to the patient and you can never let him down or her down.
I think there's a lot of work yet to be done in the space of caregiver support. Absolutely agree with you. That's actually like etched into the bottom of my paper here. So something that I'll think about, because it's hugely important. And the person sitting on the couch with the patient is equally as important. And making sure we know where those resources are is huge. You're right. Thank you for your perspective and for being so wonderful.
I consistently say to my patients, when you physically have prostate cancer or bladder cancer, and you have it emotionally, you have it too, because you have it emotionally, and you're dealing with it too. And it's true, you have to be able to, it's a partnership there, and you've got to be able to address both sides of it, and not forget.
Thank you.
And I think as we go forward with these survivorship clinics, the patients need to really understand, what is the survivorship clinic going to do for me?
Yeah.
And what is the benefit? Because if it's just another appointment, another visit, they're tired of doctor appointments and physical therapy and social work and blah, blah, blah. So, you know, how is this going to be different from what I'm doing currently?
That's a great point, and I'm sure there are data out there, probably not bladder cancer specific, but other cancer specific, about the benefits of that. And I think how clinics are structured are very different depending on the institution. Like at UNC, the survivorship clinics that we have are mostly run by APPs. But there's other institutions where it's just like one big survivorship visit with like a primary care, an oncology person, some other like people, and then they transition back to their oncology team for the surveillance part. There's a lot of different models. So I think I agree with like, does it extra visits and extra burdens and extra hardships, like that can be a hard sell. So definitely highlighting some of the potential benefits and gathering some data from other cancers, I think is a really great idea. Thanks, Karen. Yes.
And
please.
a quick service announcement. I know we're at time, but I did want to let you know that we do have this room till 2:30. If you want to continue the conversation, it is available for us. Thank you.
I just would like to add, I really liked your idea from survivorship through thrivership. I think at some point in clinical care, I am introducing the idea during my visits what survivorship is, and that we are officially graduating you into this new territory where we are watching for the nutrition and the colonoscopies and whatever else. I do think I like tangible results, so I really would love that the task force actually comes up with some kind of a standard, even though we're not standardizing across cancer care, but some kind of an actual form that all of us can pull in from the Beacon site and use for all of these visits, just highlighting, again, not just cancer care, but the bladder cancer specifics, whether that's nutritional deficiencies or vitamin deficiencies. Are you dealing with a peristomal hernia? Are you having recurrent UTIs with the neobladder from improper emptying? You know, whatever that is, I think it would be pretty awesome if we would come up with an actual document that all of us could use.
Can we get Jim? Thank you.
I go to the VA. I talk to a lot of veterans. And one of the challenges I have now is talking to veterans who understand. I'll talk to someone and they'll say, "Did you see your doctor today?" "No, I saw a PA." You know, or I saw a practitioner. And I think a part of them feeling good about following up with their health care is understanding that this is your health team, or what the role is in the team. You know, that lack of understanding, I think, can really slow down the process in terms of them wanting to come back and be and participate.
I think that's a great point. I think every institution does it differently. I do run our testicular cancer survivorship program, so maybe that's what my colleagues were confusing me with in that survey. But the general kind of standard of care is that my physician colleagues who either did the surgery or did the chemotherapy will pull me into the room and say, "This is Mary Dunn. She runs our testicular cancer survivorship program. She's one of our nurse practitioners. She's going to be taking over your surveillance care." So we have that kind of contact so that like patients feel a sense of security knowing that their physician has that trust in me to kind of take things over. Of course, they can choose not to see me and see their physicians, but I think that personal connection helps, and I think we don't always do a great job of like pointing out who is who on the team and who is doing what. So I think that's another really good idea for I have some sort of tip sheet in mind about maybe just like describing the role of people who may be on your team in like a one-pager and put it in the survivorship. Thank you. We are at 12:33. This has been fantastic. Thank you all so much for your input, for your participation. If you would like to be on the email list, if you are not already on the list for that, this list is just for, we do quarterly meetings. Please feel free to come up and include, and we would love to have everyone's input. If you want to chat, I'll be around. Any other questions? You guys have been awesome. Thank you so much. And thanks to Krisztina for being my partner in crime.